glycemic goals for our patients with diabetes. By and large, our goal should be less than 7% without causing hypoglycemia. Now we are looking at the time in range provided by the continuous glucose monitoring, and we're looking at a time in range of more than 70% for non-pregnant adults, with a time below range of less than 4% and a time below range of less than 54 being less than 1%, and the time in range being more than 70%. That's what we are aiming at, and that corresponds with a glycemic target, HbA1c target of less than 7%. And when you're looking at the pre-pandal and post-pandal targets, we are looking at a pre-pandal target of between 80 to 130%. A peak post-pandal plasma glucose of less than 180 is what the ADA recommends. And the A1C of less than 7% in most of our patients. But in patients who have got no cardiovascular risk, have got new onset of diabetes as we are discussing today, we need to look at a target of less than 6.5% also without causing hypoglycemia, because of the availability of agents that do not cause hypoglycemia. Now, there is a great importance of glycemic variability. So we just spoke about, we have different time in range thresholds being suggested and the targets being suggested. For type 2 diabetes, the target is more than 70% being in time in range, and for pregnancy we would like to have a target of more than 80% or 90%, with a more stringent threshold being set for the time in range. How we need to look at a comprehensive approach towards reducing the complications of diabetes, and this can be achieved by lifestyle modification and diabetes education, which is very important. And then glycemic management is only one aspect of it, but the other important aspects are blood pressure management, lipid management, and using agents with the cardiovascular and renal benefit, as we just discussed about the use of GLP-1 analogs, the SGLT2 inhibitors, which provide the additional cardiovascular and renal protection. The use of these agents, you should look at using these agents whenever there is a high cardiovascular risk, and you should either stratify patients with the cardiovascular risk and consider using these two agents which have been shown to have the cardiovascular protective effect. Now, coming to the management of hypertension, as we've seen from our own study, the Indian diabetes study, we had 42% of patients at onset having the hypertension. And if you look at other studies which have looked at patients with diabetes of at least 5 to 10 years duration, you find that almost 60 to 70% of them have presence of hypertension. And it is important to treat this hypertension and treat hypertension whenever the initial BP is more than 140 by 90, and start with one agent. When the BP is more than 160 by 100, start with two agents. And lifestyle management is very important, as we discussed about the lifestyle management of which achieving glycemic control. Similarly, lifestyle management is also very important here. And also look at presence of albuminuria. If you have albuminuria, then you have to choose ACE inhibitors or ARBs or CCBs or diuretics. Start with these agents. When albuminuria is not there, then you would still use ACE inhibitors or ARBs, because they have got additional benefits in people with diabetes. And then the other class of drugs that are considered are CCBs, diuretics. And when you have more resistant hypertension, even in spite of the use of 3 or more agents, then you would consider having combination therapy or adding on a diuretic and substituting with the aldosterone antagonist. So these are all the therapeutic options that you have to keep in mind when you have to control hypertension. Now, coming to the lipid management, it's very important that we understand that, as I was highlighting from our India diabetes study, that 80% of people with diabetes at onset of diabetes itself had more than one lipid abnormality. And what we say is that the target should be customized based on presence of other risk factors or not. Those who do not have other risk factors also, just with the presence of diabetes itself, have a high risk, and the target of our LDL should be less than 100, target for non-HDL should be less than 130, and the target for ApoB should be less than 90. In those who have got a very high risk, as evidenced by the presence of 2 or more other risk factors other than diabetes, there the target should be less than 70%, 70 milligrams LDL, less than 100 milligrams for the non-HDL cholesterol, and less than 80 for the ApoB levels. And when we are seeing a patient who has got previous history of cardiovascular disease along with diabetes, then he falls into the extremely high risk category. And here the target of LDL should be less than 55, and target for non-HDL cholesterol should be less than 80, and the target for ApoB should be less than 70. So this is how the target should be decided, based on the presence or absence of other comorbidities, other atherosclerotic cardiovascular disease risk factors, and the presence of previous history of cardiovascular disease. And the therapies that we need to choose from are the lifestyle modifications. Lifestyle therapies are also very important. Then you have got pharmacological therapies, statins being the primary choice, and then you have the other agents like fibrates, omega-3 fish oils, and also PCSK9 inhibitors, and several other new drugs which are coming in. And if you look at the indications for statins, they are listed out here.
Can we reverse type 2 diabetes, reverse it without drugs, with the help of only diet and lifestyle modification?
The last few years, probably, we have got a lot of information coming in from the studies done by Dr. Roy Taylor and his colleagues from across UK, and also we have some of the studies done in India also, which have shown that reversal of diabetes is possible, or we could say that remission of diabetes is possible even without medications. What we are saying is that with just intensive lifestyle changes, we are able to bring back the people to normalcy without requiring the use of medication. This is particularly possible in people in their early phase of diabetes, within the first few years of diabetes, and particularly when you're speaking about of new onset diabetes, this is quite possible, and this is more possible in people who are overweight, obese, and we have elegant data from the different trials which have been conducted by Dr. Roy Taylor, where he conducted this direct study and the counterpoint study, which were done in different setups. One was in an experimental setup and in a very closely monitored setup, and the direct study was done in a more generalized primary care setup. In both the setups, what was seen was that at least in 50% of patients you could achieve some degree of reversal. How long does this remission last is something which we have to wait and see, but certainly what we see is that there is a possibility of remission of diabetes with intensive lifestyle changes done right at the onset of diabetes.
How safe is it to use pioglitazone with respect to bladder cancer risk?
Yeah, so I think there was some concern raised initially about bladder cancer risk, and but subsequent follow data has not shown this to be a major concern, and so therefore pioglitazone does not cause bladder cancer. It has been conclusively shown in different studies. The only concerns that we have when you're using pioglitazone is the weight gain that can happen, and the fact that if we have somebody with a incipient heart failure, then we should not use it in such people, because it can precipitate a heart failure in such people who have got incipient heart failure. But it has got some cardiovascular benefits, and the other aspect of pioglitazone is that it has got a good durable action. So if somebody responds very well to pioglitazone, he has a very durable glycemic control, and once he started on that, he can actually be on that for many years without actually having to add any other therapy. So that's what we have seen in many of our patients who have been on pioglitazone, and when we stop pioglitazone for any reason, if they develop heart failure or if they have increase in weight, if you want to stop them, then we have quite a good bit of a sort of problem in terms of reaching the glycemic control with other agents, because more than one agent needs to be added to get them to glycemic control.
In newly diagnosed diabetic condition, which are the safe OHA for anesthesia purposes?
Anesthesia purpose. Okay.
He talks about best possible treatment for A1C 10.
Now with A1C of 10%.